First, I just want to thank Dr. Nelson for inviting me to give this talk, and I'm really here to present on behalf of my colleagues at the International Association of Providers of AIDS Care. I'm going to talk about a few examples of fast-track city successes, and then talk a little bit about the quality of life survey that's being conducted by IAPAC. So the Fast Track Cities initiative was first conceived of by UNAIDS, IAPAC, and UN Habitat in the city of Paris in July of 2014. And by August of that year, the partnership had been formalized. And then in December of 2014, the initiative was officially launched on World AIDS Day in Paris, so exactly 5 years ago, yesterday, with 26 cities initially signing the Paris Declaration. And now we have over 300 cities as of the end of October of 2019 participating in the Fast Track Cities initiative. So why the emphasis on cities? Well, if you look at the distribution of HIV, it's clear that about 200 cities account for approximately 60% of people living with HIV, and that a single city alone actually might be home to more than 40% of people living with HIV in a country. So by getting support from a sufficient number of cities, we actually may be able to impact the HIV epidemic in an entire country. Cities also tend to be laboratories of innovation. They tend to be areas where people are innovative and creative. Creative ideas and solutions will emerge. And so by engaging cities, we are also able to ensure that there's local responsibility and we can target our responses to a specific neighborhood or even a district in a city. And then, of course, I think that we can all agree that we're doing the right thing. We can work with and leverage the political will of our city leaders to prioritize our efforts to getting to zero, while also addressing health inequalities, reaching populations that are most at need, and really trying to close the gap around care and prevention. So the Paris Declaration is really a living body of work. It was first signed in 2014, as I mentioned, but really has evolved to incorporate some of the new science and data around HIV. So while emphasis is still on getting to zero, in 2018, the declaration was amended to include scientific concepts such as U equals U, or undetectable equals untransmittable, primary HIV prevention, biomedical prevention such as pre-exposure prophylaxis, as well as incorporating a greater involvement and meaningful involvement of people living with HIV in the decision-making processes. The declaration now also includes emphasis on syndemic conditions such as mental health and substance abuse, HIV comorbidities, TB, hepatitis B, and hepatitis C elimination. So when a city decides to engage as a fast-track city, we try to ensure that there is political commitment from mayors and other elected officials. And then technically, IAPAC works with the cities and their health departments to build care continuum dashboards, which I'll show you an example of in a second, and to convene and develop implementation strategies. And of course, depending on the location, the process may include multiple jurisdictions and multiple stakeholders. So here's an example of the city dashboard for Kigali. As I mentioned, IAPAC works with the health departments to generate baseline data for the HIV care continuum, for the 90-90-90 goals, and other relevant data such as mapping of HIV testing and care and treatment centers. So here on this map, you can see I've highlighted testing locations, ART centers, and HIV support services that are available in Kigali. The dashboards are really a tool to help us monitor progress in achieving the goals, promote stakeholder accountability, and to communicate momentum towards achieving the goals. IAPAC also specifically provides assistance with implementation planning, capacity building, stigma elimination, community education, and quality of life and care assessments. So this might include support such as assisting with plan development or clinician trainings. IAPAC also helps to convene regional and national and local workshops. And then last September, we actually had the first Fast Track Cities Conference, which was held in London. which highlighted progress, lessons learned, and remaining challenges. The next Fast Track Cities Conference will be in Lisbon in September of 2020, and you're all hopefully are invited and will attend. And then IAPAC is also developing a best practices repository and focusing on implementation science training and other research studies. So I want to spend the next few minutes highlighting 2 cities and 1 country. The first is Bangkok, which was one of the first cities to endorse the Paris Declaration. The second is Kiev, which is an example where political will has really been key to the city's response. And the third is Rwanda, our host country for this meeting, and I'll have some emphasis on activities happening here in Kigali. I do want to highlight that these are just examples. As I mentioned before, we have over 300 cities participating in the Fast Track Cities initiative. But I think that these are 3 examples of where we've seen successful response, and some of the elements in their responses I think can be inspirational to other cities. So the first city is Bangkok. Bangkok is a city of 8 million people. 1/3 of the Thai population living with HIV reside in Bangkok, which equates to about 77,000 people. The key populations there include young men who have sex with men, persons who inject drugs, and commercial sex workers. Bangkok was one of the first cities to endorse the Paris Declaration, and you can see from this graph that they've achieved the first 90, so many of their activities are focused on the second and third 90s. So what has Bangkok been doing? Programmatically, the city has worked to improve HIV in key population estimation to really try to identify gaps in their data and their response. They've also initiated and supported key population-led health services, so they're using MSM and transgender-focused health centers as a place to integrate and encourage HIV testing among these populations. They've rolled out rapid, targeted PrEP provision for key populations, and the city now provides over 80% of the country's PrEP prescriptions. They've also initiated same-day ART with outreach to key populations, and 74% of patients at the Thai Red Cross Clinic are starting a 2-week course of ART at the time of diagnosis. So importantly also, I think in the theme of this, session is that they've also scaled up system-wide stigma reduction in health clinics. With respect to resource allocation, the city has increased domestic funding for key population-led organizations and approved funding to provide ART to undocumented migrants and non-Thai residents. And in terms of political advocacy, which really is a foundation of the Fast Track Cities approach, data are being used to track progress towards the 90-90-90 targets, and multi-stakeholder coordination is underway with the establishment of a steering committee that's developed and endorsed a roadmap to achieve the 90-90-90 targets. So some of the challenges that remain in Thailand include engaging engaging the non-NGO sector in their response, coordinating with multiple stakeholders, and managing political turnover and priorities. So the next city I want to highlight is Kiev. Kiev is the capital city of Ukraine. It has a population of 3 million individuals and an estimated 20,000 of the 240,000 people living with HIV reside in Kiev. Key populations include persons who inject drugs, commercial sex workers, and men who have sex with men. And the city of Kiev endorsed the Paris Declaration in April 2016. And you can see from this graph that they have achieved the third 90, with 96% of people living with HIV achieving viral suppression. So impressive work happening in Kiev. So what have they been doing in their response? Well, as I mentioned before, I think political will and leadership have really been at the heart of the response in Kiev. Programmatically, the city has supported its 2017 to 2021 targets. They plan to invest $8.5 million towards HIV prevention, treatment, and really importantly in their context, harm reduction activities. HIV testing has been decentralized from HIV centers to community health facilities in order to reduce stigma and also increase access to available services. And PrEP availability has also increased with emphasis on reaching these key populations. Politically, there remains sustained political commitment, and the mayor or deputy mayor of Kiev participate in all local and also international meetings and committee meetings around achieving the targets. Community mobilization has also included establishing intersectoral partnerships. For example, the city of Kiev provides space free of charge for youth HIV testing in one of its facilities. So importantly, what's happened in Kiev is that the city's response and their improvements in achieving 90-90 have inspired other Eastern European cities, such as Odessa, to actually join the Fast Track Cities initiative. Key challenges in Kiev include linkage. So, it's not enough, obviously, to test individuals, but you have to make sure that you get them into care. And so they're looking at models to use community health workers to do that. They also are still facing a lot of stigma and discrimination, again, based on the key populations that are being affected by HIV in Kiev. And then they're also working on increasing access to services, so dealing with things like ARV stockouts and making sure that clinics are open during hours when those individuals that need to access them can be there. So my last example is focused on Rwanda. So as a country, Rwanda has made great progress towards achieving the 90-90-90 goals, with 94% of people diagnosed, 93% of those individuals on ART as of 2018. In October, results from the Rwanda population-based HIV Impact Assessment were first released, which showed that the country was at 84, 98, and 90, as you can see in the blue bars, and therefore may be one of the first countries in Africa to achieve all three targets. In Kigali, among the estimated 1.1 million residents, about 57,000 are people living with HIV, making it home to 1/4 of the country's population living with HIV. In 2015, the mayor of Kigali endorsed the Paris Declaration, and as of most recently, Kigali's targets are at 91, 94, and 89%. So I think a round of applause for all of the efforts that are happening here. So what's been happening in Kigali to make such great progress? Well, programmatically, the city released a strategic plan which focuses on increasing the proportion of people who know their HIV status, increasing voluntary male medical circumcision and condom use, and decreasing mother-to-child transmission. Additionally, they've revised their HIV and STI guidelines to focus on commercial sex workers, adolescents, and young women. Resources have been allocated to increase access to youth-friendly centers for sexual and reproductive health services, and data have been used to actually map hotspots where there is commercial sex work occurring to establish condom dispensaries in these regions or in these areas of Kigali. Politically, there's been emphasis on multi-sectoral responses to the epidemic, with leadership working very closely with UNAIDS, but also with leadership in Kigali and the mayors of its 3 districts. Community involvement has also been a central tenet to the response here, with active engagement and participation of both the faith-based community as well as civil society, including organizing a meeting on human rights and advocacy and training individuals at that meeting. And finally, stakeholder coordination has included uniting stakeholders at the sector and district level to ensure really a coordinated response. So I've shown you 3 examples of fast-track cities and really tried to highlight where their successes are. But I think it's important to mention that these cities also face challenges. And one of those challenges, as Dr. Nelson mentioned, is really pervasive anywhere, which is stigma and discrimination. And so I'd like to spend the last few minutes of my talk sharing some data from IAPAC, from the results of their Fast Track Cities Quality of Life Survey. And this work was led by Iman Sidibe, and I'm really presenting the work that she has done. So I want to make sure to acknowledge that. So as we frame our conversation moving into stigma and discrimination, again, as Dr. Nelson mentioned, we really have focused our goals on the first 3 90s. But a 4th goal, and perhaps maybe what should be the first goal, is really improving the quality of life of people living with HIV. We know that stigma is associated with HIV leads to poor emotional well-being, obviously discrimination, violence, marginalization, and subsequent reduced quality of life. We also know that stigma results in barriers to HIV testing, a lack of disclosure, and really leads to difficulties across the care continuum. And also that social determinants of life, such as poverty or laws and policies that reinforce stigmatization, such as criminalization, also add to stigma and discrimination against people living with HIV. So Fast Track Cities has really tried to take a holistic approach in their programming and in their response to stigma and discrimination. They have focused on exploring the social, political, and economic factors affecting the overall well-being of people living with HIV. They're using quality of life indicators to measure and understand what those barriers are, and then using that data to try to inform our response. So the survey focused on 3 key areas: overall well-being, which included emotional well-being as well as physical well-being, social participation and interpersonal relationships, which also included social inclusion, and then basic needs and quality of health services, which include economic and structural factors. The survey was conducted as a one-time cross-sectional self-administered survey, which included 20 fast-track cities, which I'll show you in a minute, and aimed to have a target sample size of 300 respondents per city. There were 45 questions in the survey, which came from the following validated tools that you can see listed here. And then the survey was translated into 8 languages to try to reduce any bias associated with having to respond to a survey in a foreign language. So here's a list of the cities included in the survey. Again, the regions were Europe, Africa, North America, Latin America, and the Caribbean, and then Asia Pacific. And I'll just highlight a few of the key findings, again, mostly as they relate to stigma and discrimination. So at the time of the analysis, there were 3,206 participants, of which 17% were from Europe, 35% from Africa, 12% from North America, 29% from Latin America, and 7% from Asia Pacific. You can see from the bar charts here, the majority of the participants were male, except in African countries where women outnumbered men 2 to 1. In terms of living with HIV and antiretroviral therapy use, about 40% of respondents had been living with HIV for more than a decade. And the majority, 80%, reported consistently being on ART. However, the lowest levels were reported in Africa, in the African countries responding to the survey. When participants were asked about disclosure, about 1/3 of them indicated that they had disclosed to family members, and disclosure to friends and community members was slightly higher in North America and Europe compared to other regions responding to the survey. When you take a closer look at disclosure, the survey results also found that disclosure was higher among respondents from African, Asian, and Latin American regions at 37%, and disclosure in the workplace and community was lower than other regions at 7% and 8%. And importantly, although stigma and discrimination were issues in all regions, respondents living in African countries reported experiencing more stigma and discrimination in their communities, so 51%, and then also reported experiencing stigma and discrimination in their health facilities at 36%. So despite the high rates of stigma and discrimination, many of the respondents, about 40%, reported having a positive outlook on life, which I think is extremely important and shows some resiliency. However, African respondents were less likely to report having a positive outlook compared to other regions. And then finally, approximately 40% of respondents reported being satisfied with their overall quality of life, with about 1/4 of them reporting being very satisfied. And again, you can see from this graph that these responses were really similar across all regions participating in the survey. So in conclusion, I think progress towards achieving 90-90-90 is certainly underway. We certainly have the science and the community support and the political commitment to achieve these goals. Obviously, cities are critical in our response and success in these efforts, and they really are uniquely positioned to help us attain both local, national, and global goals. And again, I've tried to highlight a few examples where this is the case. However, I think we would all agree that we really need a comprehensive approach, which includes improving the quality of life for people living with HIV and as well as those vulnerable to HIV, and eliminating stigma and discrimination to ensure access to life-saving treatment and prevention programs for everyone. So with that, I just want to acknowledge my IAPAC colleagues who helped put together this presentation, our partners at UNAIDS, VIV, ICW, our Fast Track City partners who helped complete the survey, and then for every Fast Track City, we always want to make sure that we thank our Fast Track City mayors, our key opinion leaders, as well as our other partners. So thank you.